Hi everyone, my name is Letitia Warnick. I am the PGY2 Pharmacy Resident in Internal Medicine at Buffalo General Medical Center. For our second topic in Women's Health series, we will be talking about pregnancy and emergency contraception. This is a really important topic for patients, as patients will always have questions regarding this high number of available products available and how to use them. By the end of this presentation, you should be able to describe the process of pregnancy, recommend types of barrier methods to prevent pregnancy and transmission of sexually transmitted infections, and recommend options for emergency contraception. I have some readings posted here for you. In general, there's a lot of information out there about these topics, so I would encourage you to look through these readings and websites and familiarize yourself with the products that are available. In talking about the reproductive cycle, it's important that we start with review of the menstruation cycle. The phases of the menstrual cycle include the follicular phase, ovulation phase, luteal phase, and the menstruation phase. We start off with the menstrual phase in the first 3 to 5 days. During this bleeding, part of the layers of the endometrium get shut off. Menstruation will only occur if the released egg is not fertilized. Lack of menstruation may be indicative of pregnancy. However, it may also be due to some other causes, such as stress or poor health. After menstruation, we move into the follicular or proliferative phase. During this phase, the primary follicles in the ovary grow to become a fully mature follicle, and simultaneously, the endometrium of the uterus regenerates through proliferation. The secretion of gonadotropins, LH and FSH, increases gradually during the follicular phase and stimulates both follicular development as well as secretion of the estrogens by the growing follicles. Both the LH, the luteinizing hormone, and FSH, the follicular stimulating hormone, attain a peak level in the middle of the cycle, approximately day 14. The maximum level of LH during the mid-cycle is called the LH surge, and you can see that there with that pink line surging up around day 14. The LH surge induces rupture of the follicle, thereby releasing the egg. This is also called ovulation. Ovulation will occur on day 14 with the release of the egg from the ovary. Next, we move into the luteal phase, which starts on day 15. For this phase, the follicle transforms into the corpus luteum. In the absence of fertilization, the corpus luteum degenerates. This degeneration causes disintegration of the endometrium, again leading to menstruation, marking the start of a new cycle. It's also important to understand the timing of fertility when we're talking about the menstrual cycle. Women are most fertile during ovulation, and the window of fertility is approximately 5 days surrounding ovulation, or again around day 14 of the menstrual cycle. This may be different based on each woman. It may be closer to day 13 or day closer to 15. However, this is an estimate, and patients should be aware that around day 14 there is a higher risk of fertility. And this is also important in order to understand how some of the agents work to prevent pregnancy. In looking at how we go from conception to pregnancy, the process of pregnancy starts with ovulation. As noted on the previous slide, a mature egg is released from the ovary, pushed down the fallopian tube, and is available to be fertilized by the sperm. The lining of the uterus has thickened to prepare for implantation of the fertilized egg. Fertilization will occur from the fusion of the sperm with the egg. From here, we get the formation of a zygote. This zygote will then divide into multiple cells, forming a blastocyst. Pregnancy will occur when the blastocyst successfully implants into the uterus. If fertilization and implantation do not occur, the menstrual cycle will continue with menstruation. Now that we have a basic understanding of how pregnancy happens, we will move into talking about the methods and strategies for prevention. There are a lot of different contraceptives available, and there are many factors that we need to consider when choosing the best one. Obviously, patient comfort and understanding is important, and we want patients to use the products appropriately. It's also important to know the risks and benefits of each product. When talking with the patients, it's important to understand the patient's ultimate fertility goals and sexual behaviors, as this may influence what products you choose. Personal preference and cost will also play a large role. So next, we're going to move into talking about the different types of barrier contraceptives. This image depicts all of the available contraceptive devices and lists them in order of most to least effective in preventing pregnancy. In general, the risks of pregnancy increase with improper use of all of these devices, so it's important that we as pharmacists are knowledgeable about these products so that we can educate our patients appropriately. Starting at the top of this picture, we have the two most effective methods. Device implantation is available for both men and women and has a longer lasting effect of a few years, again, based on the product. For women, the intrauterine device can be hormonal, lasting anywhere between 3 to 5 years, again, based on the product, or a copper IUD, which can be effective for up to 10 years. Sterilization is another option for men with a vasectomy, or for women, a hysterectomy, and other procedures. An important counseling point for sterilization is that depending on the procedure performed, patients should use a backup method of contraception for at least 3 months after the procedure. Next, we'll move into talking about the devices. As we talk about each one, try to focus on the differences between each one and the counseling pearls that you believe the patient should know prior to use. The first one we'll talk about is Diaphragm. It's a small, dome-shaped device made of latex or silicone that will fit inside the vagina and covers the cervix. Hence, it will prevent sperm from reaching the uterus. This device can be inserted up to 6 hours prior to intercourse and can be kept in the vagina for up to 24 hours. Other advantages include protection from sexually transmitted infections. Important to note, it does not protect against HIV. It's also controlled by females, and they are reusable. Disadvantages include that these devices are only available via prescription. These devices need to be fitted and sized by a gynecologist, so that could be a limitation to use. They can also be difficult to place, and there is somewhat reduced spontaneity with using these products. Other side effects include the risks of urinary tract infections, yeast infections, and toxic shock syndrome. Next, we have the male condom, which is probably the most common and well-known barrier contraceptive. Condoms prevent direct contact of the penis to the vagina, again, preventing sperm from reaching the egg. Advantages of these products is that, in addition to preventing pregnancy, most agents will prevent against sexually transmitted infections. It's important to note, I have listed at the bottom of the slide, the natural membrane ones only protect against pregnancy, not sexually transmitted infections or viral infections. Disadvantages include decreased efficacy with oil-based lubricants, possible decreased sensitivity of the glans penis, and allergies, as the most common products are made with latex. It's also important to note that the latex male condoms are preferred. They also contain another product available is the polyurethane ones. And again, in talking about the natural membrane ones, they only protect against pregnancy. The next agent is the female condom, which is a pouch that lines the vagina to prevent sperm from reaching the uterus. Similar to the diaphragm, advantages include insertion up to 8 hours prior to intercourse, and these agents also provide protection from sexually transmitted infections, again, not HIV. And they are also female controlled. Also, other similar disadvantages to the diaphragm exist regarding insertion, reduced spontaneity, and the risks for infections. Next, we have a cervical cap, which is a small, thin, latex or plastic dome shaped like a thimble that fits tightly over the cervix. Unique advantages to this agent include protection against sexually transmitted infections, not HIV, and these agents can be filled with spermicide, again, to increase efficacy. One important point to note about this is that this agent is prescription only, and it has similar disadvantages to the other devices that we've already discussed.